Udah datang dia. Thank you so much, Professor Cecilia.
Hello, how are you?
Amazing. I'm great. Thank you. You?
Busy too, but it's nighttime here, so
yeah. Yes.
I'm trying to have enough light.
It's 7 a.m. in the morning now. So we will start 1 hour later.
Ah, okay. So 1 hour yet.
Yeah.
Okay. I will be back.
Okay, thank you.
The Faculty of Medicine of Universitas Sebelas Maret Surakarta has grown rapidly over the years. Established on March 11, 1976, it has positioned itself to become the leading institution in Indonesia. Strategies and activities implemented at the faculty level are geared towards being an internationally acknowledged medical and education institution. The Faculty of Medicine of Universitas Sebelas Maret strives to provide high-quality medical education to produce competent, global-minded, and community-oriented graduates. Universitas Sebelas Maret is located in Surakarta, colloquially known as Solo, a city in central Java, Indonesia. The city is located within a 50-minute flight from Jakarta and 1-hour flight from Bali. The Faculty of Medicine of Universitas Sebelas Maret is looking for students full of dreams and ambition, who not only have the ability to solve problems, but independently seek out problems to solve, and who have the desire to pioneer new medicines and medical treatments. The mission of the faculty is developing globally accepted medical knowledge and technology through basic science research, biomedicine, clinic, medical education, community, and translational research to support public health. Conducting relevant and accountable community services as needed by the society, and organizing the Faculty of Medicine based on good faculty governance. At the Faculty of Medicine of Universitas Sebelas Maret, students learn about medical treatments and conduct research for medical advancements. Students work with the goal of becoming trusted physicians and researchers who will change the field of medicine. Supported by 310 competent lecturers, including 19 professors in 21 departments and research centers, adequate facilities, and UNS Hospital, the Faculty of Medicine of Universitas Sebelas Maret has been an internationally reputable education institution. Moreover, the facility is equipped with IT facilities and information system that are integrated with the university system, a computer-based test room and a convenient academic atmosphere and green campus. Library featuring thousands of books and providing access to a wide variety of international journals, which is expected to enhance the learning of the students, faculty, and researchers. Partnership and strong collaborations have become inseparable parts of our faculty, without which progress in education research and community service wouldn't have been achieved. The Faculty of Medicine of Universitas Sebelas Maret Surakarta has grown rapidly over the years. Established on March 11, 1976, it has positioned itself to become the leading institution in Indonesia. Strategies and activities implemented at the faculty level are geared towards being an internationally acknowledged medical and education institution. The Faculty of Medicine of Universitas Sebelas Maret strives to provide high-quality medical education to produce competent, global-minded, and community-oriented graduates. Universitas Sebelas Maret is located in Surakarta, colloquially known as Solo, a city in central Java, Indonesia. The city is located within a 50-minute flight from Jakarta and 1-hour flight from Bali. The Faculty of Medicine of Universitas Sebelas Maret is looking for students full of dreams and ambition, who not only have the ability to solve problems, but independently seek out problems to solve, and who have the desire to pioneer new medicines and medical treatments. The mission of the faculty is developing globally accepted medical knowledge and technology through basic science research, biomedicine, clinic, medical education, community, and translational research to support public health. Conducting relevant and accountable community services as needed by the society, and organizing the Faculty of Medicine based on good faculty governance. At the Faculty of Medicine of Universitas Sebelas Maret, students learn about medical treatments and conduct research for medical advancements. Students work with the goal of becoming trusted physicians and researchers who will change the field of medicine. Supported by 310 competent lecturers, including 19 professors in 21 departments and research centers, adequate facilities, and UNS Hospital, the Faculty of Medicine of Universitas Sebelas Maret has been an internationally reputable education institution. Moreover, the facility is equipped with IT facilities and information system that are integrated with the university system, a computer-based test room in a convenient academic atmosphere and green campus. Library featuring thousands of books and providing access to a wide variety of international journals, which is expected to enhance the learning of the students, faculty, and researchers. Partnership and strong collaborations have become inseparable parts of our faculty, without which progress in education research and community service wouldn't have been achieved. The Faculty of Medicine of Universitas Sebelas Maret Surakarta has grown rapidly over the years. Established on March 11, 1976, it has positioned itself to become the leading institution in Indonesia. Strategies and activities implemented at the faculty level are geared towards being an internationally acknowledged medical and education institution. The Faculty of Medicine of Universitas Sebelas Maret strives to provide high-quality medical education to produce competent, global-minded, and community-oriented graduates. Universitas Sebelas Maret is located in Surakarta, colloquially known as Solo, a city in central Java, Indonesia. The city is located within a 50-minute flight from Jakarta and one
Tunjukkan baktimu,
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
The Honorable Professor Dr. Revi, Specialist of Pulmonology Consultant, the Dean of Faculty of Medicine, Universitas Sebelas Maret. Welcome to Professor Revi. Thank you very much for your attendance. The Honorable Mrs. Ika Sumiarsi, SST M.Kes, the Head of Midwifery Department, Universitas Sebelas Maret, and all of our committee and the honorable participants. Good morning, ladies and gentlemen. Welcome to the first International Conference on Midwifery Updates 2021. My name is Wahidah Maulina, as the Master of Ceremony of today's event. This event is organized by Department of Midwifery, Faculty of Medicine, Universitas Sebelas Maret Surakarta. Before we begin, we will show you the rules of this conference. Ladies and gentlemen, full participation during this conference is required. Secondly, please open your camera during this conference. This conference also will be recorded, and participants are required to fill the attendance link by the end of this event. This certificate will be sent to your registered email address, so please to type your certificates with the correct email address. And the last, please mute your microphone during the conference unless you have Q&A session. Ladies and gentlemen, I will read the schedule of International Conference of Midwifery Updates. First of all, welcome remarks from Professor Dr. Revi. Second session is the main presentation by Professor Cecilia. And second session is second speaker by Dr. Revi Gama Hatta Novika. And the last session is oral presentation by the chosen participants. So ladies and gentlemen, now our first agenda, we will start our conference by opening speech by Professor Dr. Revi, Specialist of Pulmonology Consultant, the Dean of Faculty of Medicine, Universitas Sebelas Maret. For Professor Dr. Revi, the time is yours.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Honorable Professor Cecilia and Jevitt, PhD. Honorable Dr. Revi Gama Hatta Novika, SST M.Kes, Speaker. And also Honorable Midwifery Program DOctor of Medical Faculty Universitas Sebelas Maret Surakarta, Ibu Ika Sumiarsi, SST M.Kes, and also all of audience here. First of all, let us share thanks to Allah, who has given us mercy and blessing to have can gather here in this webinar on International Conference of Midwifery Update. Secondly, welcome to Professor Cecilia Jevitt, RM, CNM, ARNP, PhD, if AGNM, very long title, and Dr. Revi, Gama, Hatta, M.Kes. Nice to meet you, Professor Cecilia and Jevitt. And they are who kindly share her knowledge, experience, and time in this occasion to share a new perspective regarding women's health issue during COVID-19 pandemic. Thirdly, allow me to express my deepest appreciation to Midwifery Program Head of Medical Faculty, Universitas Sebelas Maret, Ibu Ika Sumiarsi, and team who consistently and continuously make a valuable contribution to national development, not only to bring UNS to world-class university, but also make an impact to empower women during this pandemic. Okay, and the last, thank you very much for all webinar participants who have been very enthusiastic in participating in this event. I hope this event success and provides the greatest benefit for us, for UNS and also in Indonesia. Okay, thank you for all. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much for the speech, Professor, and hopefully our agenda will be successful. So ladies and gentlemen, we come to our second agenda, the presentation by first speaker, which will be handled by our moderator, Mrs. Nurul Jannatul Wahidah, SST M.Kes. Mrs. Nurul is our midwifery lecturer in our department. She graduated from Master of Reproductive Health Science, Airlangga University. She joined several projects of research, which one of those is an Indonesian National Adult Mental Health Survey. Her main research interest is reproductive health science and involved in the clinical trial of ethanol extract of Gendarusa capsule as non-hormonal contraceptive for men. Very interesting. And last year, she published her book about health reproductive with the title Kesehatan Reproduksi dan Tumbuh Kembang Janin hingga Lansia pada Perempuan, or Health Reproductive Growth and Development of Women. Please welcome Mrs. Nurul Jannatul Wahidah.
Thank you very much, Mrs. Rufida Maulina, for giving me time handling these sections. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Honorable Professor Cecilia M. Jevitt, respectable Dr. Revi Gama Hatta Novika SST M.Kes, Honorable Dean of Medical Faculty Universitas Sebelas Maret Surakarta, Professor Dr. Reviono, respectable Midwifery Program DOctor of Medical Faculty Universitas Sebelas Maret Surakarta, Ibu Ika Sumiarsi SST M.Kes, and all audience here. Welcome to our International Conference of Midwifery Update 2021. My name is Nurul Jannatul Wahidah. As a moderator of these sections, will guide this presentation for our two best speakers. In these sections, let me tell you how the presentation will go. Each speaker will be invited to present their presentation for 45 minutes, and in the last 15 minutes, there will be Q&A section for each speaker. For all audience here, please remember that if you want to ask some questions for our speaker, for the booth speaker, for the first and second speaker, please write down your question into Zoom chat or use the raise hand icon when you want to ask to our speakers in Q&A section. Ladies and gentlemen, COVID-19 first documented in Wuhan, China at the end of 2019 has rapidly spread across the globe and infecting tens of millions of people around the world, especially affected maternal and perinatal health not only directly through the infection itself, but also indirectly as a consequence of the changes in the healthcare services or socio-economic circumstances. To provide a comprehensive overview on this broad topic, we conducted this conference and we bring out our best speaker today to share all their experience related to empowering womanhood during the pandemic COVID-19. First speaker will present about women and health issues during the rise of pandemic, how COVID-19 affected women's lives, women's fertility, pregnancy, and a newborn baby. She is the Midwifery Program Director of British University, Columbia. She gained her Master Science in Nursing from Emory University. She gained as Applied Medical Anthropologist from University of South Florida, Tampa, became Associate Professor of Midwifery at the University of South Florida College of Nursing with dual appointment to Department of Obstetrics and Gynecology, USF College of Medicine, and promoted to Professor at Clinical Track, Yale University at 2018. She focused on research during the last 20 years about prenatal weight gain for those with obesity. She has authored numerous research manuscripts and book chapters on this topic. So you can see here her resume right here. It is very amazing to have her resume until 56 pages, and I couldn't read it all to you guys. Let's we invite together Professor Cecilia M. Jevitt. Time is yours. Hello, Professor Cecil.
Thank you all. Thank you for inviting me today.
You're welcome, Professor Cecil. You are very kind. We have a differences time for about 12 hours, Indonesia and Florida, but you give your time to share your experience and your knowledge to us here. It is very amazing.
Yes, it's nighttime where I am, but
Yeah.
I'm never too tired to talk with midwives.
All right. So it is your time, Prof. Cecil.
I'm going to share my screen so that I
All
can
right.
bring up some slides.
Yep.
There. All right. Again, I want to thank you for inviting me. I actually have two homes. On the left is a picture of the city of Vancouver. That's where I work and teach. Right now, I'm at my home in Florida in the United States. Two very different locations, but it's nighttime in both of those places. I want to tell you a little bit about Canada because it's so different from Indonesia. Canada is the second largest country in the world by land mass, but compared to Indonesia, it has a very small population. And 90% of that population lives right here along the US border because the rest of Canada is too cold most of the year to live in. The province where I work, British Columbia, is the third most populous province in Canada. Canada has a population, a total population of 5 million, so small compared to Indonesia. And Vancouver, where I work, is the largest city. We have about 40,000 births per year in British Columbia. Many more in Canada, but still not as many as in Indonesia. Our midwifery is relatively new, like yours in Indonesia. It was legalized in 1998. Ours was the first midwifery education program in British Columbia, and it's still the only educational program here. In British Columbia, midwives are autonomous prescribing primary care providers. We work independently and are paid for our work by the Ministry of Health. Our first graduates from the University of British Columbia graduated in 2005. Next year is the 20th anniversary of the founding of our program. We now have more than 350 midwives in British Columbia, and across the province, we are responsible for 25% of the prenatal care, and we deliver 25% of the babies. So let's turn to the COVID-19 pandemic. And I can speak to North America. I know your experience in Indonesia is a little bit different, and maybe you'll tell me about some of that when we do the question and answer period. So I'm going to cover COVID-19 and perinatal health, protective adaptations to survive COVID-19, improving care as the pandemic waxes and wanes, that is, comes and goes. In Canada and in the United States, we are in our fourth wave of the pandemic, particularly with the Delta variant rising to levels that are higher than we experienced with the original COVID virus. And then we'll talk about applying lessons that we've learned during the pandemic to future health emergencies. I was hoping we'd be able to do a poll so I could see how many of you have been ill with COVID and how many of you had a family member sick with COVID. In British Columbia, all but 2 of our midwives avoided becoming infected with COVID. We went into lockdown very quickly, and we spread vaccine quickly. The latest statistics today are that in British Columbia and across Canada, 83% of adults older than 11 years have had 1 vaccine, and 79% of those adults have received 2 vaccines. Canada claims to have the highest COVID vaccination rate in the entire world. Many of us lost loved ones, family members, and friends during the pandemic. And I grieve with you for those that you have lost, and I am sorry for those losses. Hopefully, our continued work against the pandemic will reduce future losses. SARS-CoV-2, as we've learned, is very contagious. The literature talks about COVID being more contagious than measles. Many of us have lost experience with measles because of the measles vaccine. But when I was a child in the United States, every spring there were epidemics of measles, mumps, German measles, and women and their newborns suffered from having those diseases while pregnant. The transmission rate of COVID, its row, its reproduction number is 2.2. That means basically for every 1 person infected, they will average infecting another 2 people. The incubation period, the average incubation period, is 5 days, but people can experience symptoms as soon as 2 days after exposure and as long as 14 days after exposure. Therefore, you'll see that countries have put in place 14-day quarantines when people have symptoms or test positive. 95% of those exposed who show symptoms will show those symptoms by 12.5 days post-exposure. We initially didn't know how COVID was spread, but now we know that transmission in most cases is through respiratory droplets and aerosolized droplets that go out into the air. You can get COVID by contact with contaminated physical objects, but that's a much lower rate of transmission. We discovered by tracking cases early on that some of humans' most enjoyable and relaxing activities, singing together or praying by singing together, push droplets and aerosolized particles in the air, and are some of the activities that most quickly spread COVID. The COVID virus can persist in aerosols in the air for up to 3 hours. But we don't know how infectious those particles remain when they're in the air. We do know that COVID particles can persist on plastic and stainless steel up to 5 days, but there's a significant reduction in them after 72 hours, and contact with things that have COVID particles on them is not the main way of transmission. I think you are all familiar with the symptoms of COVID. The most telling symptom is a fever, and 85% of those who have COVID symptoms have fever. Cough, tiredness, or exhaustion are also common symptoms, including shortness of breath or difficulty breathing. Those are signs of bronchitis and a pending COVID pneumonia. Those who are sick describe being sicker than they have ever been sick in their lives, with headache, joint or muscle pain. And the symptoms that are unique to COVID include olfactory dysfunction, which means you lose your sense of smell. That's the way most people discover that they're coming down with COVID. They can't smell their food anymore, or perfumes or flowers. Gustatory dysfunction means you've kind of lost your appetite. Our sense of smell is linked with our sense of appetite, and when we can't smell, we don't want to eat much. And when you're sick, you lose appetite. Gastrointestinal symptoms are much smaller. About 5% of people have nausea and vomiting, and another 3 to 4% have diarrhea. So all of these symptoms are obvious in people who are tested for COVID. Keep in mind that many people are exposed to COVID, would test positive, but never have symptoms. There are heavy social effects on families, serious effects that were imposed as countries and local communities worked to prevent the spread of COVID. The quarantine, the social lockdown, can cause loss of work, loss of jobs, and loss of family income. Not everyone can work online. Many of us who are faculty members were lucky enough to be able to work online. You are essential healthcare providers, and you had to make adaptations but continued working. Those who worked in restaurants, or who worked in schools, or who were housekeepers or store clerks may have temporarily lost their jobs and lost the security that income provides. Loss of income reduces food access, and a family might lose safe housing. In Canada and the United States, governments quickly enacted laws that prevented people from being removed from their housing if they couldn't pay for it. And they enacted food programs so that people weren't hungry. What the governments couldn't fix was the separation from friends and family who might give support. My husband and I are both professors, and we worked at home for 18 months in social isolation. I saw people if I went to the hospital, but we couldn't return to the United States to visit our children, our parents, and our siblings for those 18 months. That's very emotionally difficult for families. When families are pushed together into quarantine, that can cause a great deal of stress. Initially, families felt isolation kind of as a vacation together. But pretty soon, when you are with family members 24/7, you can feel a real lack of privacy and feel crowded. In North America, many women were quarantined with abusive husbands or partners. Domestic violence, including spouse abuse and child abuse, rose sharply in North America during the pandemic. Here's what COVID cases looked like on the 7th of March in 2020 when the pandemic was occurred. There were areas of infection in many countries around the globe. This latest photo shows the distribution as of August 9th. More than 200 million cases were confirmed worldwide. The darker the red in the photo, the more confirmed cases. You might also notice that those are countries with high populations and with good record keeping. We say that there are more than 200 million confirmed cases. We won't actually have numbers on COVID infections or COVID deaths for many years after the pandemic is settled, because some countries simply can't keep ahead of the statistics. In some states in the United States and other countries, governors and administrators have stopped collecting data on COVID because they don't want the population to know how bad the situation is. There have been more than 4 million deaths worldwide that are attributed to COVID. The COVID messenger RNA gets into cells easily through the ACE2 receptor sites. Those are the angiotensin converting enzyme sites that are located throughout our body. From receptor sites on the cell surface, COVID messenger RNA moves through the cell and uses host cell RNA to replicate itself. It then leaves the cell and spreads through the body. So first, let's look at the effect on fertility. We talked about COVID entering the ACE2 receptor sites. So organs in the body with more ACE2 receptor sites will have more inflammation from COVID. Luckily, In the female reproductive organs, the fallopian tubes, the ovary, the vagina, the cervix, and the endometrium, there are few ACE2 receptor sites. So female reproductive organs are somewhat protected from inflammation with COVID. However, male reproductive organs, especially the testes and the Leydig and Sertoli cells and the seminal vesicles that produce sperm, have many ACE2 receptor sites. So male reproductive organs can be a site of COVID infection that may affect fertility. We know from experience with other viral infections, hepatitis B, mumps, and HIV, those viruses enter the male reproductive tract and may impair fertility by causing orchitis, that's inflammation of the testicles. Men who have had it tell me it's extremely painful. COVID orchitis has been demonstrated during autopsies of men who died from COVID infection. So the future fertility of men might be affected by COVID. We will need years of research in the future to really demonstrate what happens. Right now, we have no documented reduction in fertility for women who've been infected with COVID. COVID can have effects on pregnancy. However, most reproductive age women are young, and younger women. Can I add? Somebody has a microphone open, I think. Ah, that's better, thank you. Most reproductive age women are young, and younger women fare better with COVID than women over the age of 50. However, with the Delta variant, there are increased numbers of deaths for younger adults. Many infections during pregnancy are asymptomatic. And here's an example of that. One of the New York City hospitals decided to test all admissions randomly for COVID-19. Almost 16% of their admissions to labor and delivery were positive for COVID, but only 20% of those who tested positive had symptoms at admission. We are at greatest risk of being exposed to COVID from those who are asymptomatic and think that they're well. COVID has the potential of causing disease in almost all body systems. What we know most clearly is the pneumonia and respiratory distress syndrome from COVID infection in the lungs. Lung tissue is rich in ACE2 receptors. There are concerns about transmission in breast milk. I can talk about that in a little bit. We do know that COVID can cross the placenta, but what worries us most is potential inflammation of the placenta and clotting within the placenta that affects fetal growth. There are documented cases of vertical transmission, that's transmission from the mother to the fetus in utero. Women with COVID are very prone to blood clots and emboli. If the heart is affected, there's cardiac strain, and general endothelial dysfunction in the circulatory system. This is one of the contributors to increased preeclampsia and eclampsia in women with COVID. We know that COVID attacks the immune system and alters its function, and individuals with COVID can have a cytokine storm that is a rapid escalation of toxic cytokines, which interfere with their ability to fight off COVID. In the adrenal hypothalamic pituitary axis, there's increased anxiety and stress. We've already got anxiety and stress about the pandemic before we ever get the disease. A review article by Wastnej said that the risk of severe coronavirus during pregnancy might be slightly higher than adults in the general population. Risk factors for severe COVID are similar in pregnancy to the general population. I'll go over these on another slide. We're not sure how COVID gets from the mother to the fetus. We know it can happen. Vertical transmission is low, and severe neonatal disease seems to be rare. Antenatal corticosteroid use for threatened or preterm birth is used in North America. It's safe for the mother and it's safe for the fetus and may be beneficial in treating individuals with severe disease, those who require hospitalization. The management advice is for clinicians to treat potential blood clots and thromboemboli in mothers quickly and consider prophylaxis in women who are at high risk for clotting events. Okay. So we have COVID symptoms, and as maternity providers, we continually educate women about these symptoms and encourage them to come for testing early if they're feeling like they're coming down for a cold, if they have fever or cough. It's important for us, now that there are vaccines, to encourage women to accept vaccines. Many women are cautious about taking vaccines during pregnancy. Our data from North America show that it's much safer for a mother to be vaccinated during pregnancy than to suffer COVID infection. We have thousands of case histories of women, of pregnant women, who were hospitalized with COVID. We have no documented cases of women who were hospitalized for vaccine reactions following the COVID vaccine. A newborn with COVID infection might be born with shortness of breath, a fever, some thrombocytopenia with abnormal liver function, a rapid heart rate, vomiting, and pneumothorax. But this syndrome is very rare in newborns. There are conditions that make it more dangerous for pregnant women to be infected with COVID. These are the comorbid conditions that increase risk in pregnant women for all sorts of complications: diabetes, hypertension, other pre-existing maternal disease, particularly autoimmune diseases, such as rheumatoid arthritis or multiple sclerosis. With those autoimmune diseases, women's immune systems are already compromised and are less able to fight off COVID RNA. Individuals with obesity have slightly impaired immune systems and are more prone to COVID infections. Also, adipose tissue or fatty tissue has many ACE2 receptors. Therefore, adipose tissue or fatty tissue can be a site of COVID inflammation. Cigarette smoking, which causes lung damage, makes lungs easier to be infected with COVID. Any substance use, including alcohol use, can change women's immune systems, and their health isn't optimal, and they are more prone to infection with COVID virus. So here are our current recommendations in North America for COVID-19 management during pregnancy. We educate women that during pregnancy, their risk might be a little bit higher than non-pregnant individuals. And if they have other pre-pregnancy disease, they may be at elevated risk. We educate women that vertical transmission is possible, but we're not sure how that happens and why that happens in some women, but not others. Severe neonatal disease appears to be rare. Steroid use for threatened preterm labor is safe for the mother and may be beneficial for the treatment of COVID. We encourage women, if they are at high risk for blood clotting or emboli, to consider prophylaxis. Mothers with COVID-19 should be encouraged to breastfeed. COVID-19 has been isolated in some breast milk samples. It's a small portion, and I have those numbers coming up. But maternal antibodies protect the fetus, so women should breastfeed. They are encouraged, if they have active infection, to wear a mask while they're breastfeeding or caring for the newborn. We don't know if asymptomatic COVID-19 in pregnancy will have any future implications for maternal or fetal health. And we ask that clinicians really think about the wider implications of the pandemic and encourage women who are pregnant and their families to be vaccinated to decrease the spread of COVID further in the community. Here's a population-based study from Ontario, Canada. That's the most populous province in Canada. In Ontario, researchers looked at more than 2 million pregnancies that occurred from January to December 2020, including 13,000 that resulted in stillbirth. For that group, the mean preterm birth rate was 7.96%. the mean stillbirth rate was 0.5%. They compared those rates, which were births that occurred during the pandemic, to the same period for the last 17 years. So I think this was a brilliant design. The researchers looked at all the births so far that occurred in Ontario during the pandemic and compared them to all the births that occurred in the previous 17 years in Ontario. The rates for preterm birth and stillbirth were the same. There was no significant difference. So it looks like the pandemic has not had a large effect on pregnancies. There are two different views of preterm birth and COVID-19. If the woman is symptomatic, if she's ill with COVID, she's at risk for severe illness. In the studies published, 6 to 7% of pregnant women with symptomatic COVID required an ICU admission. And an ICU admission means intubation and mechanical ventilation. Those women were at risk for preterm birth, and that is averaging about 25% of women who had symptomatic COVID had preterm birth. And the women who needed ICU admission were at risk for preterm delivery by cesarean section. If women don't have COVID symptoms or don't have COVID, their risk of complications is the same as the general population. Now, here's some work that I thought was really interesting. There are studies from Denmark and Ireland that document that women who were at home, quarantined during the early pandemic, had significantly reduced rates of preterm labor. Those two countries had their preterm labor rates reduced by half in some parts of the pandemic. And researchers thinking about that is that women were home, they were resting, and they were relieved of work-related stress. And that's what lowered those preterm birth rates. We still have a great deal of research to do about the pandemic and perinatal health. We know that for breastfeeding, there's potential transmission from infected mother to the newborn by droplet spread while the mother is breastfeeding. Some hospitals initially separated mothers and newborns, trying to protect the newborn. The newborn really benefits from the immunoglobulins and immune cells in maternal breast milk. And we don't want to sabotage or make early breastfeeding more difficult for women. One study documented COVID-19 messenger RNA in 4% of the breast milk from women who were symptomatic with COVID. That's very small. Brown and other researchers did a survey of just over 1,000 women in the United Kingdom, women who were breastfeeding. 41% of those women felt that breastfeeding was protected by the quarantine. They didn't have to commute to work. There was less requirement for them to socialize. They didn't have to visit family, visit friends, or go out. they had greater time for rest, and they were less afraid of giving COVID, being exposed to it and giving it to the newborn. So they felt social isolation supported their breastfeeding. Another 27% struggled during the pandemic. They said anxiety about getting COVID was increased. These women felt that the quarantine made it more difficult for them to get assistance. They were separated from family, like their mothers, their aunts, or their sisters, who could have helped them with breastfeeding knowledge and support. In North America and in Europe, there was no in-person lactation support. So lactation consultants and midwives talked with women over Zoom the way I'm talking with you, trying to help them with breastfeeding. It was something, but it wasn't effective for all women. Many women stopped breastfeeding during the pandemic because of anxieties and lack of support, particularly women from ethnic minorities. Many women early in the pandemic were incorrectly told not to breastfeed, and many introduced formula feeding earlier than they planned. And that forced them to stop breastfeeding earlier than they planned. Effects on the newborn. Preterm birth was the most common complication, about 24% across studies, and a small number of newborns' throat swabs were positive for COVID. Newborns with negative throat swabs have been shown to have elevated immunoglobulin M and IgG against SARS-CoV-2. So maternal IgG can cross the placenta to protect the fetus. But the fetus having IgM shows that the fetus mounted its own immune response against COVID. In newborns, nucleic acid tests in infected newborns, tests of vaginal secretions, breast milk, amniotic fluid, placental blood, and placental tissues were negative. So we don't know how these women fight COVID off, but still have newborns who are symptomatic. Infected newborns most often do well. You are all familiar with the protective adaptations that we used: quarantining, social isolation, masking, eye protection, gloves, surface cleaning, and finally, vaccination. All of these used together can be very effective in preventing the spread of COVID. But you know this. Using this protection day after day after day really adds to workload and is pretty tiring. So there are stressful effects to all of this effective protection against COVID. So maybe you could take just a minute to put in the chat box some of the psychosocial problems caused by use of social distancing and personal protective equipment. Go ahead and type them out in the chat box. I'm not seeing any answers about those problems. Maybe it's difficult for you all to type in the chat box. So here are some of the psychosocial problems that we know about. So anxiety in the mother and stress. Some of that comes from being without family, being alone to care for children who aren't in school. Here's a woman having an ultrasound exam and her husband can't be with her because family members are very limited during medical exams and hospital visits. Here's a mother at the bottom who's exhausted from childcare because she can't get help with the childcare. Women have been isolated from many of their usual places of support. So places of religious worship, whether it's a mosque, a temple, or a church. I don't know the Indonesian experience, but in North America and in Europe, churches were closed to prevent the spread of COVID. And certainly, we receive great support from our religious families. Down in the left-hand corner, there's a grandmother with a newborn and a mother. Many families were isolated from their relatives and their elders who usually provided support. And then down at the lower right, women were isolated from their friends. And those are some of our best supports. Even though we were able to call our friends over the phone, have Zoom chats or phone chats with them, it's not the same as being in a room or sharing a meal, being with them in close proximity. Another effect of all of our protective equipment, decreased facial recognition. Who can tell what we look like and what we're saying when we're behind masks? We forget how much of our communication is based in facial expressions and our ability to do some basic lip reading. So our communication was inhibited while we are masked up. There is long-term stress and anxiety from the pandemic. All of this stress affects our hypothalamic pituitary adrenal axis hormones. That tends to increase blood pressure. It increases insulin resistance, and it can make epigenetic changes in the fetus. So here's the woman, the pregnant woman, the fetus inside, whether it's male or female, is exposed to stress hormones, cytokines from inflammation, and that makes epigenetic changes that make those babies more sensitive to stress and more anxious as they grow. If the fetus is a female fetus, she has all of the eggs in her ovaries that she will have for a lifetime, and epigenetic switches that increase lifelong anxiety can be flipped in those eggs. We are what happened to our grandmothers, many of us. So there are many anxiety reduction methods that we can suggest for women. Rest, time with close family when possible, calls, video chats, time outdoors, physical activity, deep breathing, prayer, and meditation. We need to explain treatments and health education carefully and again and again. When we are stressed, as we are during a pandemic, our memories aren't as good as they are outside of pandemic. If we give women written information or have that information on a website that they can refer to, it's much better. We should try to give women as much control as possible over their own choices in their healthcare. We should be encouraging our clinics and our hospitals to assure that women have one companion, one family member who can be with them during birth. And then we need to encourage vaccination. And I know that vaccination has been difficult in Indonesia. We need to care for ourselves as midwives. If we're not healthy, we can't care for the women and the families who depend on us. In ourselves, fear of the unknown creates chronic anxiety. Anytime we have to change practice, it's a little bit stressful. And we had to do a lot of changing to use personal protective equipment. Sometimes our patients who are unhappy with quarantine and COVID policies are angry. And they express that anger to us. Maybe not as much in Indonesia, but you know, Americans are very vocal when they're not happy. So many healthcare providers have to provide care cheerfully, even when the patients are angry. Many of our coworkers are sick with COVID or are home caring for children and family members who are sick with COVID. And that means all of us work longer hours. Compassion fatigue is when we are just worn out and we find it hard to be sympathetic. This midwife in the photo is one of my former students. She had that baby during COVID last year and worked while pregnant during the pandemic in all of her gear. So maybe when we ask questions, we can talk about some other things that you recommended to your patients to decrease stress during COVID. And then think about what you have done to help yourself decrease your own stress during the pandemic. It may be things like prayer. Maybe you've gone outside walking with friends where you can be free of your mask for a while. Maybe you're running or doing some exercise, or maybe it's a video chat, having a cup of coffee virtually with a friend. As I finish, I want us to think of the many environmental threats to health. This probably won't be the last pandemic many of you practice through. So we need to learn how we managed the COVID emergency and apply it to other emergencies. Earthquakes, erupting volcanoes, tsunamis. I know you have those in Indonesia. In British Columbia, we have earthquakes, we have wildfires, and we have serious climate change from global warming. All of these emergencies will affect our midwifery care in the future. So how can we optimize the healthcare response for women during emergencies? We need to work between emergencies to protect food systems, to assure that government safety plans include provisions for pregnant women and infants. We need to promote vaccination against disease, and we all need to work to limit environmental pollution, to reduce waste, and use renewable energy sources that will limit global warming. These don't sound like they're midwifery. They are life actions that all of us can do as we share the world. And it will make the world safer for all of us. And my biggest message to all of you at your excellent universities is to do research now, collect statistics now about COVID-19 in Indonesia that will be useful in the future. Here are some questions you might answer with your research. Does COVID-19 have a long-term effect on women and newborns? How can women best be helped through social isolation during pregnancy? How can families be encouraged to accept vaccines? How can midwives help deliver vaccines quickly in populations? And then what support for women and pregnant women was missing from this pandemic that could be applied to future emergencies? I'm happy to answer questions. I couldn't see my clock. I hope I haven't gone too late for you all. I'm going to stop screen sharing, and maybe we have a little time for questions yet.
All right, thank you very much, Professor Cecil. It is very great. It is make me very interested to do research about COVID-19 and the maternal health itself. Okay, here there are two questions in my chat rooms. First questions come from Mrs. Rufida Maulina. She said, thank you for the presentation, Professor. I want to ask how if pregnant women consume high dose of vitamin D, such as 1,000 until 5,000 IU, is it safe and can prevent from several COVID symptoms if they got infected?
In North America, we recommend vitamin D supplements during pregnancy.
Right.
Not for COVID, but for general bone health and good immune function. There would be a good research study for you to look at. Did women who took high levels of vitamin D resist infection better than women who weren't using vitamin D? A question to be answered.
All right. Okay. So, and the second question, as a midwife, how to treat pregnant women with abusive partner while they are in quarantine? Because in Indonesia, mostly the abusive partner is not detected, and women sometimes afraid to tell or go to their healthcare providers regarding these issues. Does separation from her abusive partners is recommended?
Working with families where there is domestic abuse is difficult when there is enforced isolation. One of the things we discovered in Canada, we thought virtual prenatal care over Zoom, would be widely accepted by women. We found out that some women said, we don't have any privacy in our homes. We don't want our mother-in-laws or our husbands or other people in the house to hear what we say to our midwife. So what we did was do a phone call or a video conference with women in the morning, and then, excuse me, women came by themselves to their prenatal visits in the afternoon. That's when they had private time with the midwife and could say if they were suffering abuse. We are all taught to recognize the physical signs of abuse. And in the United States, excuse me a minute.
Yeah, it's okay, Professor.
In the United States and Canada, we are legally required to report signs of abuse, but sometimes we don't do that because we don't want the pregnant woman to be hurt further.
Right.
We do have a series of women's shelters in both countries where women can go and they can and be protected from an abusive husband. And we will help women with that, but it is made more difficult by the pandemic.
And the last question, Prof. Cecil. Is there any correlations between the women who have been infected by COVID-19, then when they are pregnant, they have intrauterine fetal deaths? Is there any research about it? Because we also found some pregnant women having it, maybe around 2 until 3% around us.
So the study from Ontario, and you have those references, and I think maybe I also sent the articles in case you couldn't get a hold of them. That study from Ontario says there is no increase in stillbirth rates for women who had COVID. I think we still have a lot to learn about COVID, and I also think it may depend on the healthcare of the woman. Women in countries with large healthcare systems may have lower rates of stillbirth during COVID than women in countries, I mean, think of rural South America or very rural United States or rural Africa where there is limited healthcare. Those women may have COVID, suffer more with the COVID, and then have a higher chance of a stillbirth.
Okay, it is the last question, Professor. I'm sorry. I'm Gita, originally from Indonesia. Numerous studies have found that many nursing mothers didn't breastfeeding during the pandemic. This condition leads to numerous violations of the code of marketing of breast milk substitutes in several areas of Yogyakarta province. During this pandemic, there were numerous code violations. What about the condition in Canada, and what are your thoughts on this?
I needed to read that in the chat so that I really understood that question well. In Canada, in British Columbia, we never separated mothers and newborns. We really believe in breastfeeding. Also, in Canada, if the woman was too sick to breastfeed, we have human milk banks so that the newborn could receive pasteurized breast milk from the breast milk banks. And we never stopped taking milk donations to the milk banks. Milk banks aren't as widespread in the United States, but they are there. And I know in the United States, some hospitals quickly separated mothers from newborns and encouraged formula feeding. We aren't supporting that anymore. We have really worked across North America to have baby-friendly hospitals and limit formula feedings.
So thank you very much, Professor Cecil, for your information. All your presentations are very completely. And this, our next agenda, we will have some photo sessions from Prof. Cecil with all of audience here in this Zoom group. For panitia, please. Sudah siap ya, Dek? Okay, we can count it. 3, 2, 1. Okay, here there is 4 screen. Okay, for the second screens. 3, 2, 1. Okay. And the last, okay, the third script. 3, 2, 1. And the last screen. 3, 2, 1. Okay, thank you very much for all audience here. Thank you very much for Prof. Cecil. We can move to the second speakers, and maybe Prof. Cecil can take a rest first, because we know that our difference of time here is 12 hours. Thank you very much, Prof. Cecil.
Thank you all. Good night.
Good night.
Thank you.
Thank you.
Thank you. Nice to meet you.
Okay, ladies and gentlemen, let's we move to our second speaker of this seminar. She is well known in our campus, of course. She is lecturer of medical faculty and postgraduate degree of Universitas Sebelas Maret Surakarta. She gained her doctoral from medical science of Universitas Erlangga. She also member of Indonesian COVID-19 Research and Innovations Consortium, National Innovation Research Agency. She ever contribute on development of vaccines Merah Putih Indonesia, Indonesian Roadmap 2020. Her research interest is about reproductive immunological science, and her last research is entitled Stratification of Clinical Level in the Diagnosis and Management of COVID-19 with Simple Scoring System. Okay, let's we invite together Dr. Revi Gama Hatta Novika, SST M.Kes. The time is yours. Hello, Dr. Revi.
Hello, good morning.
Good morning, Dr. Revi. Okay, the time is 45 minutes for presentations and then 15 minutes for Q&A sessions.
Okay, thank you so much. Nudia as the operator, please. Okay. Okay, thank you so much, moderator. The Honorable, our Dean Faculty of Medicine, Universitas Sebelas Maret, Professor Dr. Reviono, Specialist Paru Consultant. Maybe Prof. Reviono has been leave. Our head of Midwifery Study Program, Ibu Ika Sumiarsi, Magister Kesehatan, and our guest speaker, Professor Cecilia from University of British Columbia. Thank you so much for attending here, and all participants of International Conference Midwifery. Thank you for attending here. Today, I will discuss about building confidence in COVID-19 vaccine among patients. Before I discuss about it, Prof. Cecilia have given us detailed information about what we can do to support women's health as COVID-19 pandemic continue to expand in Indonesia and in the world. Only one thing is certain. The current outbreak will have profound impact not only in the health and economic situation, but also I agree on the psychosocial well-being of societies across nation. So from the presentation of Prof. Cecilia, a key concept of physiology is homeostasis, and I agree with it, and which can be defined as the ability of a system to maintain stability when challenged with changes in the environment and other external or internal conditions. So stress is often defined as a state of real or perceived threat to homeostasis. I agree with that. And even uncertainty can be threatening when individuals imbue it with negativity. In addition to exacerbating ongoing stress, pandemic can lead to a novel condition that threaten well-being at multiple levels. And the effect of COVID-19 threaten the health and lives of women everywhere in the world, especially in places that already struggle to meet their health needs. Many public health systems are overwhelmed and face the choice about which services they can afford to provide. So one of the efforts to protect the public from this COVID-19 infection is vaccine. COVID-19 is a new thing for all of us. Therefore, what I say now is not necessarily the same in next month, maybe next year, maybe, because science is always evolving. Okay, this is from this side we can see the photo. This is our photo when vaccinating, and this is one of the contribution in supporting building confidence in vaccine from us, Faculty of Medicine, Universitas Sebelas Maret. Next. And this is our photo. Before. Okay, this is our photo in 2020 when discussing about vaccine in Indonesia with Kementerian Riset Teknologi, and now move to Kementerian Pendidikan dan Kebudayaan. Like a BRIN, maybe you know that there is a joining kementerian like that. Okay, next. Yeah, this is vaccine development roadmap. You can inform your patients they are doubtful because they don't know that this vaccine has gone through a long process to be approved. Maybe they don't know about this information. So you must know about this roadmap you can give good information to your patient. And I will discuss it in the next slide. Next. Yeah. What is defining vaccine confidence? Before that, whether in your office, hospital, or through a telehealth visit, building confidence in COVID-19 vaccination among your patients is critical to setting expectations, ensuring vaccine uptake, and helping protect our communities. Vaccine confidence may seem like a vague concept, but there are concrete things we can do to foster it and help make it visible in our health system or clinic. Yeah, here's what we'll be discussing in this presentation, and I will start it with defining vaccine confidence. We can address vaccine hesitancy by building vaccine confidence, which is a multifaceted concept based largely on trust. A person must have trust in all three of these items to feel fully confident in their decision to get vaccinated. The foundation of trust is critical, and this is something that must be built over time. This is a critical concept to think about when working with patient population who may have a history of mistrust in the medical establishment or the government. Healthcare personnel, impact of often centered is in helping patients trust in vaccine administrators, but healthcare personnel can also help build trust in the processes and policies by helping patients to understand new vaccine technologies, what to expect in terms of side effects, and how these vaccines are being continuously monitored for safety. Next. This slide shows how the willingness to accept a vaccine falls on a continuum. The vaccine demand continuum illustrates behaviors where confidence is both of feeling and can be act on. Most people may fall in the middle of this spectrum with a wait-and-see approach. We want to move people toward the right. The closer you get to active demand on the right side of the continuum, the increasing confidence the person likely feels in the vaccine, the vaccinator, and the health system because they actively cushion vaccination. this requires effort. People vote with their feet. Yeah, if there is sufficient confidence and trust and ability, then people will seek out. The vaccine, overcoming barriers to do so. People with less confidence or motivation or ability may be less willing to try and overcome real or perceived barriers to vaccination. It's also important to note where a person falls on the continuum may depend on whether the person is considering this relative to themselves or other that they care about, such a minor child, adult child with disabilities, and an older adult parent, etc. Next. So now let's discuss some specific strategies and examples for building vaccine confidence. Vaccine with confidence strategy, which aims to build confidence in COVID-19 vaccine, the provider will vaccinate, and the vaccination system is not a communication campaign, but rather a framework for thinking about intervention to increase vaccine confidence. There are three components to the framework. You can see in the slide. The first aim to build trust by sharing clear, complete, and accurate message about COVID-19 vaccine in collaboration with federal, state, and local agencies and partners. The second aim is to empower healthcare personnel by helping them to feel confident in their own decision to get vaccinated and recommend vaccination to their patients. This is the element that is most important, for our discussion. And we can see that third focus on how to engage communities in a sustainable, equitable, and inclusive way in order to increase collaboration. This is closely related to the first element about building trust. Next. The next slide. Yes, this is some of the tactics that can be using to empower healthcare personnel, engaging national professional association, health system, and healthcare personnel often and early to ensure a clear understanding of the vaccine development and approval process. I'm sorry. Okay. New vaccine technologies and the benefit of vaccination. Ensuring healthcare system and medical practice are equipped to create a culture that building confidence in COVID-19 vaccination. Strengthening the capacity of healthcare professionals to have empathetic vaccine conversation, address myth and common question, provide tailored vaccine information to patients, and use motivational interviewing maybe when needed. As member of the healthcare team, you have an important role to play in all three of these tactic. We will talk more about this. Okay, next. Next slide, we will say about case to building demand of vaccine. To build vaccine demand for the public, we need to make sure people feel the vaccine. They are easy and convenient to get, beneficial and desirable to them, and important to be able to safely return to doing many of the things they enjoy. Healthcare provider can help convey this message and information to patients wherever they interact with them. I think you can read this. And next slide. Next slide. Okay. And now, the idea of building COVID-19 vaccine confidence may seem daunting, especially in a busy workplace, but there are concrete steps for your facility can take, such as hosting discussion among staff on COVID-19 vaccine, sharing key message, highlighting success stories, and encouraging senior leaders to be vaccine champions. It is important to engage with all the types of staff across your organization in this effort, not only those in direct patient care role, to create a culture supportive of vaccination. Next. Yeah. Talking with patients about COVID-19 vaccination. Now we will spend some of the remaining time discussing specific strategies and language you can use to build confidence and address patients' question about COVID-19 vaccine. Next. Yeah. Healthcare professional, patients, and parents may be most trusted source of information on vaccination. Your answer to their question matter and will help them make an informed decision about getting a COVID-19 vaccination for themselves or their children. We are, as a healthcare provider, is a primary source. I always say to society, to our friend, we are a primary source. So give the balanced information to them. Whether you have this discussion with your parent during an in-person office or hospital encounter, through message on your patient portal, maybe at a telemedicine visit, during consultation in your pharmacy, your strong vaccine recommendation is the most important part of the conversation. Next. Yeah, listening. First, lead with listening. While a presumptive approach may be effective for routine immunization where assumed patients plan to get themselves or their children vaccinated, instead, a shared decision-making approach may be more effective for a new vaccine like COVID-19. Do not make assumption about whether or why your patient will choose to get vaccinated. Instead, begin with an open-ended question like, what are your thoughts on getting the COVID-19 vaccine? Or when wrapping up your visit with the patient, you could say, before I let you go, I have been checking in with all my patients about the COVID-19 vaccine. Have you gotten one yet? Then actively listen and seek to understand the patient point of view. Okay, next. Use patient-centered communication technique such as open-ended question to promote dialogue and get a sense of the patient readiness for vaccination and any specific concern on their mind. Paraphrase any information shared to show that you have understood it. For example, you might say, it sounds like you are most concerned about the vaccine side effects. Provide positive feedback for any protective measure they may mention they are already taking, such as wearing masks. As if you may provide some additional information from sources you trust. If they agree, they will be more willing to listen to you instead of feeling like they are involuntary receiving unsociated maybe information. Okay, next. And next is about response. Yes, it is important to show compassion and empathy in this space, as it is normal for people to have questions about a newer vaccine. Respond to their question or concern by providing answer using clear and simple language. Help navigate to accurate resources Some language you could use maybe I tried this website for accurate medical information. They also have some great resources for patients that can be found here. When considering strategies for building confidence, we must be sensitive to the long-standing health and social inequities faced by racial and ethnic minority, and other group experiencing health disparities. People may have a mistrust or fear of a healthcare provider, institution, or government after experiencing very real mistreatment or disrespectful from the institution. Avoid stigmatizing, and ensure you and your staff are trained to identify the interrupt or form of discrimination. So finally, acknowledge uncertainty about what we don't yet about COVID-19 vaccine. This can help to build trust. Next. Once you have answered their question and shared information, give your strong recommendation. Let the patient know that you recommend COVID-19 vaccination for them and tailor your recommendation to include any relevant reason why COVID-19 vaccination might be particularly important for that specific patient, such as their age, job, and health condition. Next. Give your strong recommendation. Share your own experience with getting vaccinated. The example you model in choosing to receive the vaccine is critical, as is your willingness to share and celebrate the experience. Emphasize some of the benefit to getting vaccinated, including protecting themselves and their community, and explain what activities they can safely return to doing once vaccinated. Next. Yeah, this is example. Here are some example of language you could use, such as saying. You can read in this slide. And next. These are some of key messages around COVID-19 vaccine to emphasize with patients. This can be woven into conversation or include in written material provided by your facility. The individual can help stop the pandemic by getting a COVID-19 vaccine. Maybe that the vaccine are safe, effective, and free. That after vaccination they may experience side effects. These are normal and expected, and that once fully vaccinated they can resume activities they have missed. I recommended you must give this information for your patients. Next. If patient mention myths they have heard about COVID-19 vaccine, use the conversation an opportunity to address misinformation by sharing a key facts. Let them know that it's easy to be confused by all the information that is circulating, some of which may be conflicting. Next. Help individuals find their motivation. Everyone who chooses to get vaccinated does it for a reason: to protect their family, to be less anxious, to visit their parents, or to get back to activities like seeing friends or returning to school. After addressing concern with empathy and facts, you can steer the conversation from why not to the important reason that matter to them, their why. Once someone decides on their why, help them make a commitment to get vaccinated, help make the path to vaccination shorter, easier, and less stressful for them. Okay, next. In wrapping up the conversation, encourage your patient to take at least one action, such as scheduling a vaccination appointment if they are ready to do so, or if they decline vaccination, they can read the additional information you provide them about the COVID-19 vaccine. If the patient seems open to getting vaccinated, share information on the closest vaccination site in your area. Make sure you have the information readily available in format that are easy to use and understand. If they are not ready to vaccination yet, let them know that you and other healthcare providers are always open to discussing their question or concern at future visits. Next. Recognize that it will likely take multiple encounters to move people toward vaccine acceptance. Next. Yeah, and we also can publicity available a communication toolkit specific to healthcare system with slide deck, fact sheet, social media posts, and stickers to amplify messaging around COVID-19 vaccine. I believe that all participants can do it. This is very easy. You can use Canva and others to make a poster, and this is so will make your patient understand about what we will inform. Next. Okay, I think this is my last slide. Thank you very much for your time and for all you do to think your patient and communities. Thank you.
Thank you very much, Dr. Revi. It is truly right that we have to tackle this pandemic by supporting the vaccination itself. So here, yes. There are 3 questions in my chat rooms. Okay. Wait a minute. Okay. The first question is from Sister Salsa. I am Salsa from Indonesia. I want to ask to Dr. Revi how to communicate effectively to grow confidence in the community to carry out the COVID vaccine, because there are still many people around me who don't want to get vaccinated.
Okay. Patient trust comes from us as a healthcare. If we don't believe in it, can we create confidence in our patient? So, provide balanced information about the benefit and possibilities that occur, because positive perception will form trust. So, I will say in Indonesia, untuk lebih memperjelasnya, jadi seperti ini. You must, seperti yang sudah saya jelaskan tadi di depan, Anda harus percaya dulu terhadap vaksin ini. Saya memberikan gambaran tentang roadmap tadi. Roadmap itu tidak diketahui banyak orang, hanya kami yang ada di konsorsium vaksin yang mengetahui, dan saya informasikan kepada teman-teman mumpung di forum ini bahwa pembuatan vaksin itu tidak secepat yang kita bayangkan. Tapi prosesnya sangat panjang, mulai dari fase preklinik, klinik fase 1, klinik fase 2, klinik fase 3. Dan setelah itu masih kita masukkan ke stepnya BPOM untuk mendapatkan izin edar. Jadi yang masyarakat persepsikan itu menurut saya karena ketidaktahuan Mbak Nurul. Jadi ketidaktahuan tentang bagaimana vaksin ini sampai bisa diterima oleh masyarakat itu yang memang tidak banyak dikomunikasikan. So hari ini menjadi momen yang salah satunya saya tunggu di setiap webinar, bahwa saya bisa menyampaikan ini loh roadmap pembuatan vaksinnya. Seperti ini loh kita membuat vaksin. Sangat panjang, bahkan dari preklinik pun sudah kita lihat yang pertama adalah safety. Safety adalah yang utama, kemudian bagaimana produk biologi yang kita buat ini dapat membentuk respon imun dari hewan dulu, baru kita ke manusia, baru kita uji preklinik fase 1, 2, 3, dan tadi di roadmap bisa dilihat sangat panjang sekali prosesnya, sehingga itu mendapatkan izin edar dari BPOM untuk disuntikkan kepada kita. Itu berlaku untuk vaksin yang dari luar negeri maupun yang dari dalam negeri. Kebetulan yang merah putih ini on proses, karena membuat vaksin itu tidak semudah itu. Kalau membuat vaksin asal-asalan, kita pasti sudah dari awal juga bisa. Sudah pasti vaksin merah putih itu juga sudah pasti beredar. Tapi tidak semudah itu. So, I hope you all participant here, you must trust in this vaccine for you can get best information for your patient. I think enough.
Thank you very much, Dr. Revi. Nice answer. And then second question come from Nurvi. Hello,
Okay.
Dr. Revi. I'm Nurvi from Malang. Thanks for the presentations. I want to ask about the dose of vaccines. Previously, we know that the vaccine needed are as much as 2 doses, but recently, for Nakes added 1 additional dose. In the end, does the community also need an additional dose? Because all the time, they only know that the vaccine are required 2 doses to provide the best immunity.
Okay. The dose of vaccine is this is just like if we are give something to our body, if there is a virus, okay, when virus in our body will give an response immune. So like this, maybe in here, because all participant is Indonesia, I will give you a basic concept of vaccination like this. Vaksin itu adalah tidak untuk mencegah kita semua dari paparan virus. So, vaksin itu targetnya, karena pembuatan vaksin COVID-19 ini menggunakan skema emergensi pembuatannya, jadi target utamanya adalah agar tubuh kita itu kenal sama virusnya. Saat ada virus baru masuk, tubuh kita itu nggak bisa sadar. Tapi setelah virus ini melakukan hacking pada sel tubuh kita, sudah melakukan hacking pada banyak sel, baru tubuh kita respon. Loh, ternyata itu tadi virus. Ternyata dia adalah orang yang harus kita bunuh. Kok kita baru sadar? Karena tubuh kita nggak kenal. Tapi dengan pemberian vaksin, diharapkan tubuh kita sudah ada database tentang vaksin itu, sehingga saat virus itu baru aja masuk, tubuh kita sudah langsung bisa respon. Loh, itu ada si SARS-CoV-2, itu harus kita bunuh. Dia udah kenal. Jadi sebelum dia melakukan hacking yang ke banyak sel tubuh kita sudah protektif dulu. Dia sudah melindungi tubuh dulu. Sehingga orang yang sudah vaksin, harapannya saat dia sudah terinfeksi COVID-19, tidak sampai terjadi keparahan penyakit. Karena itu tadi, dia baru masuk tubuh kita, sudah langsung respon. Ini adalah musuh yang harus kita bunuh, like that. Jadi kenapa kok dosisnya itu seperti itu? Bisa kita analogikan seperti ini. Orang yang baru sembuh dari infeksi COVID ini, kita sarankan untuk tunda dulu pemberian vaksinnya. Karena apa? Karena tubuh kita ini sudah punya database. Dan dari hasil penelitian, database di dalam tubuh kita mampu bertahan sampai 3 bulan. Nah, pemberian dosis itu untuk sebagai penguat. Jangan-jangan ini database-nya udah mau lupa nih karena sekali lagi saya tekankan bahwa COVID ini hal yang baru untuk kita semua. Jadi sesuatu yang baru harus masih dipelajari dari berbagai sudut pandang, dari berbagai halnya, masih selalu kita teliti sampai sekarang dan bahkan mungkin masih akan berubah-ubah. Tadi saya bilang bahwa COVID ini yang sekarang saya katakan belum tentu bulan depan, belum tentu tahun depan itu dia same. Jadi masih akan banyak terjadi perubahan karena this is a newer virus. So, dosis ini diharapkan untuk sebagai booster kita. Kenapa Moderna? Nah, itu, yang baru Moderna ya benar. Kenapa Moderna ini 1 dosis? Nah, itu tergantung dari dari hasil penelitiannya itu seperti apa, kemudian dari penelitian itu dengan dosis sekian sudah mampu menimbulkan respon respon biologis tubuh kita. So ini memang akan berbeda-beda dari setiap institusi pembuat vaksin. Jadi tapi yang jelas ini sudah diuji cobakan mulai dari preklinik sampai dengan klinik fase 3. So I'm sorry, moderator, I use our language because this is a critical basic concept of vaccination. Oke.
It's okay, Dr. Revi. Biar mudah dipahami gitu ya. Oke, I wanna wait a minute. Read the message from Professor Jevitt. Thank you, Professor Gama, for these valuable presentations on encouraging vaccination. I was interested to see that the motivational interviewing technique and the phrase that you use in talking about vaccines are the same that midwives use in Canada and in the US. I admire your use of English. I can't speak a word of Bahasa Indonesia. It is late here and I'm retiring for the night. Thank you all for asking me to be a part of this conference. I wish you all safety from COVID and growth in your midwifery knowledge and skill. Thank you, Professor Jevitt. Maybe
Thank you,
see this. Yeah. Okay. We will go for the last questions. Is it okay, Dr. Revi?
Yes, okay.
Yeah. Hello, I'm Irma Maya Puspita from Surabaya. I want to ask to Dr. Revi, is there any relationship between the side effect or KIPI caused by vaccine and the level of protection provided by the vaccines, considering that currently there are several types of vaccines that are given and cause different side effects? Is the higher the protection provided by the vaccine, the higher the side effect itself?
Okay, I get it. Thank you so much for Mrs. Irma Maya from Surabaya. Jadi, so I give me permission to use Indonesian, Mrs. Nurul, because I will give this. Okay. Kalau kita berbicara tentang KIPI, jadi seperti ini. Vaksin ini saat tubuh kita di beberapa orang akan menimbulkan respon biologis yang berbeda. Jadi setiap individu itu akan memberikan respon biologis yang berbeda terhadap suatu. Kok terhadap vaksinnya? Terhadap SARS-CoV-2-nya itu responnya berbeda-beda. Seperti ini. Misal, tubuh saya ini lagi sehat walafiat. Kebetulan 1 bulan yang lalu saya terinfeksi COVID satu keluarga, tapi responnya berbeda-beda. Suami saya itu batuk-batuk yang sangat parah, tetapi tidak ada demam. Saya tidak ada gejala apapun yang muncul, dan sedikit pun tidak ada. Kemudian anak saya itu juga tidak ada gejala apapun. Ada beberapa yang responnya itu panas tinggi tapi dia tidak batuk. Ada yang saat terinfeksi dia batuk, pilek, panas tinggi, kemudian 1 minggu sembuh. Ada yang saat terinfeksi dia tidak apa-apa, kemudian tapi 1 minggu kemudian akan timbul gejala. Nah, jadi semua ini tergantung respon biologis dari diri kita. Kembali lagi tadi ke bahwa COVID-19 ini adalah virus varian baru yang memang masih akan terus kita teliti. Kenapa dia seperti ini, kenapa kok timbul seperti ini, kenapa respon biologis individu terhadap virus ini berbeda-beda. So, bisa kita ekstrapolasi ke efek vaksin. Efek vaksin pada setiap orang juga ada yang berbeda-beda. Ada yang bilang saat habis mendapatkan vaksin dia mengalami demam, ada yang tenggorokannya katanya sakit, ada yang badannya kayak orang dipukulin. So, ini adalah about biology response in our body. Jadi sebenarnya ini adalah bukan sesuatu hal yang patologis, bahwa setelah kita divaksin kemudian timbul respon, itu sebenarnya menandakan bahwa tubuh kita sedang merespon sesuatu yang masuk. Cuman responnya berbeda-beda tergantung kondisi tubuhnya. Saya pernah tanya, ada salah satu mahasiswa yang setelah vaksin itu dia panas tinggi dan lain sebagainya. Saya tanya, kamu lagi nggak baik-baik aja ya waktu vaksin? Iya, Bu, saya kemarin lagi ini, dia merasa kondisinya berbeda. Kita pasti tahu ya, kondisi kita lagi baik-baik saja atau kita sedang terjadi penurunan kesehatan, kita kan bisa merasakan sendiri. Nah, beberapa orang yang saya tanya saat setelah vaksin dia terjadi hal-hal ikutan seperti itu, ternyata memang sebagian besar adalah pada mereka yang saat disuntik vaksinasi pada hari itu dia tidak dalam kondisi yang fit 100% seperti biasanya. So, tapi itu tidak usah khawatir untuk teman-teman semua di sini, itu adalah respon biologis. Jadi kita respon biologis tubuh kita harus memahaminya dan kita juga waspada sendiri bahwa ada hal-hal yang memang harus kita perhatikan dari hal baru ini. So, kita sama-sama belajar. Saya pun juga masih belajar dari banyaknya jurnal, itu masih banyak sekali fenomena-fenomena yang saya dapatkan ya, bahkan respon-respon di beberapa negara itu juga berbeda, seperti misal hasil uji efektivitas dan si vaksin ini di negara A, B, C itu pun juga berbeda. Jadi hal baru ini mari kita pelajari bersama, dan kita sebagai tenaga kesehatan jangan sampai kita yang membuat persepsi negatif ke masyarakat. So, kita pahami dulu tentang vaksin ini. Kenapa sih kok seperti ini? Oh, di jurnal dikatakan seperti ini. Jadi kita based on jurnal, jangan based on informasi yang tidak jelas. Kita adalah primary source. We are primary source. Masyarakat menganggap kita primary source. So, we must trust in this vaccine before you give good information to your patients. Okay, it is enough, Bu Nurul.
All right, great answer, Dr. Revi. But I'm very surprising here because there are so many questions in the chat room actually. But
Okay.
Is it okay if I give you one question more, Dr. Revi? Because it's very interesting for me and maybe for all audience here.
Yes.
It comes from Mrs. Ika Yudi. Assalamualaikum Ibu Revi. I am Ika from Poltekkes Kemenkes Malang. Hope you stay in good health in order to elevate confidence of being vaccinated to expecting mother. Do we as healthcare permitted to inform adverse effects of COVID-19 on pregnancy so she will get motivated to be vaccinated? Would it lead her to anxiety or there is better way to do this? Thank you.
Assalamualaikum Bu Ika. Bu Ika dosen saya waktu di Poltekkes Malang, Bu Nurul. Oke. Jadi nyun sewu Bu Ika bahwa vaksin itu gini, saya awali dari ini ya, imunologi dari ibu hamil. Pasti ibu moderator juga tahu bahwa pregnancy immunologist is a unique immunological respon, bahwa imun biologis ibu hamil itu sedikit berbeda dengan imun pada orang yang tidak hamil pada umumnya, karena ada dua respon dari ibu dan respon dari si janin. So memang itu yang di awal dikhawatirkan, bahwa saat kita memberi vaksin jangan-jangan ada respon yang unik nih dari ibu hamil. Tapi dari beberapa, jadi kalau teman-teman membaca DC itu mereka punya aplikasi, saya lupa VSafe atau apa. Di situ di luar negeri itu bahwa orang hamil dan menyusui itu diberikan kebebasan untuk memilih sejak awal ya, memilih apakah kamu mau divaksin atau enggak. Kita kasih tahu benefit dan negatifnya. Silahkan diputuskan. Ada beberapa yang memutuskan untuk divaksin dari ibu hamil dan menyusui sejak awal, sebelum kita ada surat edaran tentang diperbolehkannya vaksin pada ibu menyusui dan ibu hamil. Di sana sudah, tapi itu berupa sebuah pilihan. Setelah itu orang-orang ibu hamil itu yang mereka bersedia untuk divaksin itu diarahkan untuk mengisi di VSafe itu. Saya belum mempelajarinya secara detail, tapi di situ tujuannya CDC itu adalah untuk mengontrol, untuk melihat apakah si ibu hamil yang sudah mendapatkan vaksin sejak awal ini mereka ada kejadian-kejadian negatif ataupun respon-respon biologis yang merugikan pada dirinya dan janinnya. Nah, dari 100% yang mengisi link tersebut itu dikatakan bahwa belum ada yang melaporkan adanya kejadian negatif. Jadi dari situ kita bisa berkaca bahwa vaksin ini aman untuk ibu hamil maupun menyusui, dan memang tidak ada transmisi langsung dari ibu ke janin. Itu penelitiannya juga sudah banyak bahwa ibu yang positif COVID anaknya itu tidak serta-merta dia juga positif, tapi ada kemungkinan penularan lewat droplet apabila misalkan breastfeeding dan lain sebagainya. Nah, dari situ menjadi dasar pengambilan keputusan di negara kita bahwa ibu hamil dan ibu menyusui diperbolehkan vaksin, karena sudah ada beberapa sumber tentang this is safe for pregnant women. So, tadi pertanyaan dari Bu Ika bahwa apakah apa tadi Ibu Nurul, saya lupa, so will get motivated to be vaccine. Yes, jadi kita harus memberikan sebuah motivasi kepada ibu hamil bahwa ini aman untuk dilakukan. Kemudian kita informasikan beberapa sumber yang valid bahwa ibu hamil itu aman karena seperti ini. Kita berikan informasi yang berimbang, yang lengkap, tetapi juga kita juga memberikan beberapa kemungkinan yang terjadi, misal seperti tadi akan ada respon biologis yang mungkin terjadi seperti panas dan lain sebagainya, but it's safe for you. Jadi ini harus kita informasikan agar ibu hamil merasa tenang, dia tidak merasa khawatir akan dirinya dan juga janinnya setelah mendapatkan vaksinasi. Tetapi juga pengalaman saya terhadap vaksinasi di wilayah kota Surakarta ini, belum semua platform itu bisa menerima ibu hamil, karena seperti serbuan vaksinasi yang kita lakukan bersama TNI, bersama M.Kes ya, itu ada beberapa tempat yang kita belum berani menerima ibu hamil untuk divaksin. Belum beraninya bukan karena efek dan lain sebagainya, karena program kita serbuan dan di situ kita tidak melibatkan opsin untuk observasi. Jadi yang kita terima adalah pasien-pasien umum yang tidak hamil dan sehat. Jadi untuk ibu hamil, setelah kita berikan informasi berimbang tadi, kita sarankan untuk ke tempat yang dia percaya, dan kita berikan gambaran tempat yang paling aman dan memungkinkan untuk ibu hamil mendapatkan vaksinasi itu seperti apa. Jadi misalkan jika vaksinasi itu diselenggarakan di rumah sakit ataupun puskesmas, yang di sana benar-benar akan diobservasi ketat, bukan di tempat yang serbuan-serbuan vaksinasi, yang di situ observasinya adalah observasi lebih ke pasien-pasien umum. Nah, seperti itu. Itu akan mengurangi kekhawatiran, sehingga mensugesti ibu hamil untuk dia merasa aman dan nyaman terhadap vaksinasi yang akan diberikan. I think enough, Mrs. Nurul.
Thank you very much, Dr. Revi. So it is wait a minute. So it is our last questions, and we are really glad to see to know your information about what is your presentation, Dr. Revi. Thank you very much for coming here and give us so many knowledge about the vaccination itself. So, ladies and gentlemen, we know that the pandemic has affected women tremendously. Women's experience at homes, their work and health well-beings are very, very affected, especially among women during pregnancy and childbirth. Pregnancy and childbirth can be stressful at the best of time, and coronavirus has been make the stress of the pregnant woman itself become increased. From 5 pregnant women also have a serious concern about the anxiety itself. So we as a healthcare here have to increase our knowledge, our research, and always do educating people around us, to the women, of course, actually, to increase their motivation to use the vaccination itself. And in this last sections, thank you very much for our 2 best speakers, Professor Cecilia Jevitt and also Dr. Revi Gama Hatta, SST M.Kes, for coming here for the best presentation of all us here. And I give back this conference to Mrs. Rufida Maulina. Mrs. Rufida Maulina, you can take the times.
Right. Thank you so much, Dr. Revi Gama Hatta Novika, for valuable information about vaccine and how to convince women, especially pregnant women, to be vaccinated, because it's very important nowadays. And now for today's agenda, for the next agenda, we have photos for Zoom. So please, all of the participants, to turn on your camera, and please for the committee member to screenshot the Zoom. I will count from 3 to 1. Okay. 3, 2, 1. All right. For the next slide. 3, 2, 1. All right. Thank you so much. All right, thank you very much for Mrs. Nurul Jannatul Wahidah, Professor Cecilia, and Dr. Revi Gama Hatta. We would like to share our gratitude or thanks for sharing your knowledge and experience in women's health issues during pandemic and how to convince people to be vaccinated, especially women. And we will show you the certificate for Professor Cecilia and Dr. Revi Gama Hatta. All right, this is the certificate of appreciation for Professor Cecilia. Thank you so much for the attendance and valuable information. And this is for Dr. Revi Gama Hatta Novika, sorry. And then this is certificate for Professor Cecilia. Thank you so much for your valuable information too. For the next agenda, please for selected participants to move to breakout rooms. Let me use Indonesian language. Diharapkan untuk peserta yang terpilih untuk mengikuti oral presentasi untuk masuk ke breakout room yang akan disediakan oleh panitia. This is the end of the conference, the International Conference of Midwifery updates. Thank you so much for your participation. Hopefully we can meet again in the next ICMU 2020. Don't forget to copy your attendance link before it was ended and deleted. And please type your name and email correctly. Thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Kurang.
For the participants, you can leave the Zoom chat. Let me use Indonesian language. For peserta bisa untuk meninggalkan Zoom karena acara sudah berakhir. Terima kasih atas partisipasi pada kegiatan ICMU pada tahun ini. See you next time di 2022.